Good afternoon. I'd like to welcome everybody to today's meeting of the Health and Adult Social Scrutiny Committee. My name is Jo Lawson and I'm the chair. Could I ask that the panel introduce themselves?
Thank you, Chair. Eric Firth, Dewsbury East.
Thank you, Chair. Tim Bamford, Debberdale.
Alison Munro, Almonbury Ward.
Helen Clare, Voluntary Co-op Tea.
And we are joined today for the first item on the agenda by the Children's Scrutiny panel. Would they like to also introduce themselves?
Ashley Robinson, Councillor for Linley Ward.
Anna McKirker, Denbydale Ward.
Thank you. Are there... Moving on to apologies. Are there any apologies, Chair?
We've received apologies from Kim Taylor, Co-op Tea, Councillor Jane Ryler and Councillor Habib Anzaman.
And the minutes of the previous meetings, there are two previous meetings. There is the minutes of is 27th of November and the special meeting that was held on the 10th of January. Can I have are there any matters arising from any of those sets of minutes? Can I now ask for somebody to agree that these are a true and correct record of the minutes of both meetings? Thank you. Are there any declarations of interest? And admission of the public. I believe everything will be heard in public today. Do we have any deputations or petitions?
None received, Chair.
And any public questions?
None received, Chair.
Thank you. We'll move on to item number 7 of the agenda, which is the Healthy Child Programme. If you'd like to actually introduce yourselves as well, that would be lovely. Thank you.
Good afternoon, I'm Lucy Wearmouth, Head of Improving Population Health in Public Health.
Good afternoon, Vicky Stadniki, Public Health Manager.
Good afternoon, Mohammed Zida, Senior Contracting and Procurement Manager for Public Health.
Just waiting for the slides. Okay, thanks, Vicky. Right, yes, so we're from Public Health to talk to you today about the Healthy Child Programme. We're going to start off with a bit of a general introduction to what the Healthy Child Programme is, just in case some of you aren't aware of the programme and what it does, and then we're going to talk some more in detail around the tender which we're going through at the minute. It is one of our biggest and most important contracts within public health, and we're obviously looking forward to seeking feedback from yourselves today on that. Aims for today is to provide an overview of the Healthy Child Programme and the background to the contract. We're going to present to you the vision that we've created for the new service, and we'd like to get your feedback on the vision for that. We want to update Scrutiny panel on the key milestones for the competitive tender process and to outline the governance flight path. But obviously for all of this, we're seeking your feedback and questions as well. Thank you. Okay, so just to give a bit of an introduction and just tell you a bit more generally about the programme, and then I'm going to hand over to Vicky for some more of the details. So just to share with you first why the Healthy Child Programme is so important in Kirklees. I'm going to start off with point 3 actually, which is about the statutory compliance. So elements of the Healthy Child Programme are mandated, so the delivery of this service ensures that the local authority meets its statutory duties, because certain elements are mandated, and I'll talk through that more in detail in a little bit. Second point is around health improvement and reduction in inequalities. The programme is one of the most important ways in which we can work with and support children and young people and families, right from antenatally through to age 25 for young people who have special educational needs. It is universal in its reach, so that basically means that a large majority of the programme is available for any family to access in Kirklees, but it's also important to say that it also has a targeted element as well, so it also ensures that it provides support to families and young people who may need additional support as well. And then in terms of the strategic alignment, it directly supports the delivery of the Kirklees Health and Care Plan, Health and Wellbeing Strategy, and the SEND Transformation Plan as well. So a lot of what we've done in this process, we've worked really closely with our children's colleagues as well. Right, thank you. Next slide, Vicky. So just to give you a bit of an overview of the Healthy Child programme. So it is a national programme. It's not something that just happens in Kirklees. It is mandated nationally. It's an evidence-based public health initiative with the aim to improve health and well-being of children and young people. Like I've said before, that's antenatally through to the age of 25. There's a number of focus areas for the programme. They include health and development reviews, health promotion, parenting support, and screening and immunisation. But also, what isn't on the slide, which I wanted to mention as well, was the importance of preconception care, child development, improving outcomes for children and young people, and really importantly, which is important to stress, is about ensuring that families at risk are identified at the earliest opportunity. So that's in relation both to safeguarding, but also in relation to special educational needs as well. So it's an important way that children with additional needs can be identified and supported appropriately. Okay, next slide. It's essentially health visiting and school nursing. So I'll talk you through the health visiting element of this, and this is the element which is mandated. So there are 5 mandated health visiting contacts for children from pregnancy to the age of 2 to 2.5 years. So families will receive a contact from the health visiting service antenatally from around 28 weeks of pregnancy, and then the new birth review, which needs to be between 10 and 14 days of delivery of the baby, then 6 to 8 week review, 1 year review, and then another one between the ages of 2 to 2.5. In terms of what happens at those reviews, there's a lot of kind of universal stuff which the health visiting teams will talk about with the family. So they'll look out for things like maternal mental health, infant mental health, attachment and bonding, safeguarding risk, as well as ensuring that children are meeting their developmental milestones, and when they're not, they'll obviously kind of refer on or bury some more into that. They'll also cover things like safe sleep, weaning, infant feeding, so it's a really kind of broad range of stuff which the health visitors focus on. Next slide, please. And then into the school nursing service. So this is for children aged 5 to 19. So the role of the school nurse is to provide health education on a wide range of health and wellbeing topics such as sleep, nutrition, puberty, substance misuse and sexual health, as well as giving individual support to children and families. School nurses will obviously also refer on to other agencies and organisations in Kirklees when there's additional support that's needed. Also, there's a role in terms of safeguarding children by identifying and addressing any signs of abuse or neglect. And then finally, school nurses will act as a health representative for children and young people in safeguarding meetings. So this next slide provides you with some background really to the Healthy Child programme. I won't go through this in all of the detail, but obviously you can ask questions afterwards. There's detail in the paper as well. I think that the things to highlight here really are that Public Health have directly commissioned the Locala to deliver the Healthy Child programme, and we're commissioning them until the 31st of March 2026. And then in February 2024, there was a provider selection regime decision report that was approved to commence a competitive tender process for the reprocurement of the service. In terms of the contract value, the current contract value is 7.6 million annually until the 31st of March 26, and then the new annual contract value will be 8.1 million annually from the 1st of April 26.
Thanks, Lucy. I'm just going to carry on and share the next couple of slides in terms of what the vision is for the Healthy Child programme moving forward and what's informed that vision as well. So in terms of what's informed the vision, there's several factors and a few of these are on the slide here. So we have some national Healthy Child programme commissioning guidance that we must adhere to. So that has informed and helped influence the future vision that I'll share on the next slide. We've also done a lot of work with communities, children, young people and families, and also stakeholders to really inform what that vision looks like as well. And back in 2022, we did some regional mapping work across Yorkshire and Humber, and all the 15 local authorities completed that mapping exercise, and it was really to inform what that vision looks like for us in Kirklees, and it's really influenced how we move forward with the contract. This next slide outlines what the vision is for us for the future contract. The first point being is that we want a service to make sure that it fully delivers those mandated elements of the contract that Lucy has mentioned. We need to make sure that we get those fundamentals right and really do well on the things that are mandated for us as a local authority. We also want a service to utilise a skills mix approach for delivery as well. So not all components of the Healthy Child programme needs to be delivered by a school nurse or a health visitor, and we recognise the need to utilise other professionals to deliver the contract. We also want the service to deliver an equitable, flexible and graduated approach according to need. So again, not all children, young people and families need that same level of support. So where families need more, we want to make sure that the service does flex to meet those needs. We want to ultimately improve the health and wellbeing outcomes and reduce inequalities for the 0 to 19 population and up to 25 if children and young people have special educational needs or disabilities. We also want to ensure full integration of the service within the wider system, and I'll touch on integration on the next slide. We want to make sure there's a real focus on public health prevention and early intervention. We want to stop where possible the escalation into higher end, more costly services. Also, final 2 points, we want to make sure that we work with local communities to understand what matters to them and also influence the service to make sure that we're delivering the right service and also B, where we know that families need the services as well. So this slide just covers one element of the vision, which is integration, and integration is absolutely key in the contract moving forward. We want to make sure that the new model is integrated within the wider system, but also with what's already happening within children's services as well, in terms of Families Together Gateway, family help, and aligning where possible to the SEND cluster way of working as well. We also want to make sure that the service is integrated into that wider system, and we've been working really closely with our colleagues across the system to make sure that we get the service specification right, and we've got a panel to evaluate the tenders across that system as well. This slide outlines the governance flight path for the Healthy Child programme. So it shows where we've been reporting to so far, where we're reporting to in the coming weeks and months, and also it's got some key milestones on there in terms of the tender process. And then final point on that slide is when the contract start date is, which is the 1st of April 2026. And this is our last slide, and we're really seeking feedback, as Lucy outlined earlier, from yourselves on the content of the report that we shared ahead of the meeting, and also the vision that I've just shared on the Healthy Child programme. Thank you.
Thank you for the actual report back. Can we just go back to basics? It seems to be that the mandatory visits are till the child is sort of 2.5. What kind of things, once a child is in preschool, in actual school, what kind of things can they actually expect with contact with the school nurses? How many schools does a school nurse have? And on sort of a regular basis, how often are they actually going into schools?
Just repeat your first question again.
I'm looking at the actual mandatory visits. They seem to be that what has to be done seems to stop at age 2.5, and it is like a 0 to 19 pathway. So once a child is, say, out of sort of is at preschool, going on to sort of primary school to high school, what interventions would they have with a school nurse? Are there sort of routine sort of things that they would be doing there? And also, is how many schools does one school nurse actually have? So could you sort of say, during the course of the school year, would they be there every term at their schools?
So currently within the contract that we've got at the moment, the school nurses, they have the entry point. So they undertake the National Child Measurement Programme, which is a mandatory requirement. And also there's the vision and hearing screening that happens at that time point as well. So they will get that support at that time point, and also then the school nurse will go in and assess at year 6 as well. So they'll weigh and measure the child at the year 6 point as well. At the moment, it is more on a referral basis from the school to get that school nursing support as and when children require that support. But moving forward, what we're wanting is more of that presence within that school or within that cluster of school, so that the support so that the school nurse is more closely linked with that school, and working with the school to understand what the needs are to be able to provide the right support for that school. I'm not sure whether Lucy's got anything else to add.
I think you've covered it. We don't have them with us now, but we do have the numbers of the kind of school nurses and the schools that they are attached to, but we don't have that with us today, but we can share that with you.
That's lovely, thank you. Going back to the actual entry point assessments, did you say that they were mandatory?
The National Child Measurement Programme element is mandatory, not the screening element, which is the audio element, and also the vision screening. But
going back to sort of looking at sort of the actual vision, the hearing tests, etc., and the actual child is obviously the weight, height measurement thing there. What percentage of children are actually getting there? Because looking at some of those figures, before the model was looked at, for the mandatory ones we got, they weren't very good. So is with the school-age children, how many children are actually going through that procedure?
I can get you, and I will get you the exact data, but I know that we do have real good uptake in terms of the National Child Measurement Programme and the screening data that we have got available, so I can share that after the meeting with you.
That's lovely, thank you. I'll widen it out for questions for questions from the panel. Councillor Monroe.
Thank you, Chair. So, just getting back to the mandatory visits, how do we know this is going to be enough? In the light of the fact that expectant mothers now are having to pay the National Childbirth Trust, so I understand, for antenatal and postnatal advice, and anything to do with their baby seems to be has to be so baby massage classes, things like that for little babies. Again, that has to be paid for, and I know there. I'm aware that there are some women who cannot afford to pay for antenatal advice, postnatal checkups. There are some women who are going to fall through the net unless more can be done around this prenatal or antenatal to 2.5 years. So, are you accounting for this at all in the new model? I've got other questions as well, but that's just my first question. Thanks.
Okay, I think let me know if I'm not answering this correctly, but just in terms of the mandated contacts and the support antenatally through to 2 to 2.5 years, they're all free. There's no charge for those. But what obviously we want to do is to make sure that there's equitable access for all of those. So we do know that there will be families who are less likely to access those visits for various reasons. So something that we're doing now is looking at the data, digging under the data to understand where that's happening, so that we can understand where the provider needs to potentially target differently. I think the other element in terms of falling through the gaps is another reason why we want to make sure we integrate so closely with all of the children's services, and we mean integration, I suppose, like metaphorically, but also physically as well. And that's something that we'll be looking for in the new service. That's something that we'll be asking for as part of the tender process, is how can the new provider ensure that integration happens really well, but also in terms of inequalities and inequitable access, that the provider will also present to us their ideas about how they ensure that kind of falling through the net doesn't happen, and how that team really kind of wraps around the child, that it isn't just the health visitor or the school nurse on their own. They're kind of working in partnership with a number of other organisations to ensure that doesn't happen.
The other questions are page 17, the consultation and engagement. So what was the feedback? We're not told. What did the parents and stakeholders say should be delivered? What will be delivered in a future model? What will the scope of that future model be? And how do we know that's going to be the best model? And question 5, what options were considered? You don't tell us what options were considered. You just say the option that you're taking. So if you could just answer some of those questions, I'd be grateful. Thanks.
Yeah, so in regards to the feedback from the parents and carers, and also children and young people via the Our Voice team, some of the top level findings were around the importance of face-to-face contacts. So those mandated contacts being face-to-face in the home or in the community as well. So that's something that we are writing and building into the specification moving forward. So there was also an additional ask around making sure that things are more integrated and services work together more closely, and that would both from parents and carers and also stakeholders as well. There were also an ask around additional support needs. So just in regards to your question that you asked before, we are looking to build in an additional contact to the 5 mandated. So on top of the 5 mandated, we're looking to build in and ask the provider to deliver a 3 to 4 month contact to bridge that gap between that 6 to 8 week contact and the 1 year contact. There was also feedback from, again, broadly across all children, young people, families and stakeholders around increased visibility of services and what that service delivers and what it doesn't deliver as well. So again, that's been embedded within the service specification moving forward. And that's the top things off the top of my head, but I can come back to you if anything else does.
I think it would have been helpful to have actually, so presumably if this was a survey or a consultation that parents responded to, it would have been helpful to have seen that so we knew what you were asking and what the feedback was. And I just want to know, so what options were considered, please?
So the options that we considered were this procurement, falls under the provider selection regime, which is a new set of regulations that came in specifically for health procurements in January 23. So under that new regulations, we have a number of options where we can either direct award to an existing provider, we can direct award if there's only one provider available, or we go out for a competitive process. There's a few others options there as well. So we had a look at all the possible options with procurement, and because of certain regulations within the guidance, for example, there is more than one possible provider that can deliver this service. So we can't just direct award to a provider because there's going to be some changes from the current contract to what the new contract is going to be. Considerable changes is what the regulations say. We can't continue with the existing provider, and because the market has changed as well, since we last went out for procurement nearly 10-11 years ago, we proposed all the changes and we took it to Public Health and Corporate SLT, and the decision was made that we would go out for a competitive tender process.
Thank you. Councillor Firth.
Thank you, Chair. When you opened your presentation, you touched on babies and safeguarding. And I'm not meant to ambush you, by the way, but I just picked that up this morning. It's the Babies First Trust, and it says 50,000 babies every year are caught in a trap of domestic violence, and lots of thousands are admitted to hospital. What do we do in Kirklees when we come across something like this? I'll give you the paper. I don't know if you've read it, but it might be interesting for you. It's not meant as an ambush, by the way. I'm just saying this one. Coming into Huddersfield.
I haven't seen it, but I will read it, and I think a very large component of the service specification is safeguarding. So we're getting specialist advice on that element of the service specification in terms of a safeguarding children's nurse, but also a safeguarding contact from within the local authority as well. So just to stress that out, that obviously is a very important aspect of what we want to commission, and that we'll ensure through the delivery of the service that safeguarding is obviously kind of first and foremost in terms of the contacts which health visitors and school nurses will have with children, young people and families. But I will read this and take back anything else.
If you'll read it, look into it and perhaps report back, that would be really good. Thank you.
Thank you. We've got Councillor McKercher online.
Thank you. Thanks for the presentation and the report. I just wondered, because obviously what you've asked for is feedback on the vision today, and it mentions in the vision about being led by intelligence, which obviously you've tried to do at the start with the consultation and engagement you've done so far, but what will be written into the process so that is revisited during the duration of the contract, so that we can sort of have some view on, or you can have some view on how well things are working, and we're hearing back from the families whether actually we need to make changes.
Thank you. Yeah, that's really, really important and a really good point to make. In regards to that, children and young people's voice and families' voice is a key thread throughout all the national guidance. So it will feature highly within the service specification, and also what we'll have sitting underneath essentially the service specification is the outcomes framework, and we'll measure and we'll request from the provider to make sure that we do get that feedback on regular intervals, not only just from children, young people, but also families, wider stakeholders and the workforce as well, to really continue that service improvement and understand what those needs are, what communities, families are telling us and stakeholders to shape that service moving forward as well.
Can I just add to that? Thanks, Vicky. Just in terms of how do we know how well we're doing, there's two elements to that. There's obviously the outcomes framework, which will include key performance indicators, so the kind of the quantitative stuff that we'll be assessing through quarterly monitoring with the provider. But then obviously the quality angle is really important as well. So we know that it's not just about the numbers of mandated contacts that have been delivered, but also about the quality of them. So we will have a quality element of the service specification as well, which will include things like the journey of the child. So understanding from point A to point B what's happened for that child, and that will require more of a deep dive from the service provider into the kind of the qualitative angle of what's happened. The other thing that we're really interested in, which I think speaks to your point as well, is around the contacts which aren't happening. So if we're achieving 80% of mandated contacts, well, what's happening to the 20%? So following up on those, making contacts with the families that haven't attended is really important for us as well. So I just wanted to stress that we'll kind of be measuring that through the quantitative, the easy to measure stuff, but also the quality of what's been delivered as well.
Thank you. Because that one point I raised at the last children's panel when we saw this initial data was about whether the people who are missing those contacts, are we joined up in terms of looking at them? Is it actually the same 20% who are missing contacts each time? In which case there is an urgency to trying to establish a contact. Obviously, if it's different, if people are doing most but just missing one, that is less. I mean, it's obviously ideally everyone would get all the contacts, but that's less of an issue, I think, than if some families are actually not getting any of them. And whether we have any view on that data, or if each contact is only looked at in isolation.
No, I think it's a really important point. I think some of it we'll have to we need to kind of take back and think about how that would happen, because there may be stuff around data sharing, for example, that we need to think about. But that's exactly the point around the partnership and the integrated working, that that the team kind of works around the child and the family, and that people are kind of getting missed and falling through the net. But that is an important point you've made, so we'll take that back.
Thank you. Just to go back to the mandated visits, the antenatal visits at 28 weeks, are they in addition to midwife input? So I was trying to work out why there wasn't a great input in that. Is there wasn't a good increase from like 36% to 41. So it's in addition to that. And again with the visits within the new birth visits within 14 days. Again, is that something in addition to midwives going in?
Yeah, so the antenatal contact that the health visitor does at 28 weeks or above is in addition to all the offer that they get from the midwife as well. But we are working really closely to make sure that we get that mandated contact, the antenatal one, up to reaching target as well, or beyond that target.
And again with the actual the visit within 14 days, is that in addition to midwives maybe having contact with the mothers and the babies?
It is, but there will come a point where the midwife does stop that contact. So once, so they'll discharge them from their care at a certain time point, and that could be depending on needs after the 14-day point or before that.
Yeah, no, I was just trying to get my head round, obviously, because midwives do have a statutory responsibility for mothers up and to a certain point, and I didn't know if if it was now health visitors were coming in, because I was thinking there's quite a few women that are missing out possibly on things, but it's good to know there. Helen, would you like to come in?
Hi, thank you. Just going back to those figures, the latest figures that we've got, I assume you would agree fall far below what you would hope. What sort of figure would you be looking at to achieve with a new contract? That's my first question.
So the target at the moment that we've got with the current provider is 75%. So we would be looking at, for the antenatal contact, 75% or above. Are you talking about?
So any of those, because those are the only ones that we've got.
Yeah.
In terms of what a target could possibly be, we've not got any others to sort of look at. Even though performance was questioned by the provider, by CQC. So if that's what it is currently, are you not hoping that that will increase? Because I assume that you'd be looking at like 95%.
So yeah, 2 points I think to answer with that. Yes, absolutely. Like we'll always be looking to improve. I think what we've been on a journey over the past 2 years. So it's mentioned in the report around when we had the Ofsted send inspection 2 years ago. From the time that we've been inspected 2 years ago to now, the mandated contacts have improved considerably to where they were, but that we're still on a journey with that, and we still want to continue to improve in that. All of the mandated contacts are going in the right direction. We've been really working hard on that, both ourselves and the current provider as well. In terms of the antenatal contact, because that's the one that we can see in the figures that still needs improvement. There's specific things that the provider has recently changed, such as making sure that for first-time mothers they have a face-to-face appointment rather than through like a group appointment, for example, and that's really helped to increase that, and that continues to increase. But I totally take your point about what continuing to improve, and as part of the service specification we will have clear targets for those mandated contacts. Part of how we decide what they are is also based on how we benchmark with other areas. So we would look at other local areas and basically sense check where we are with other areas, and be looking to be the same or kind of track with other local areas.
That's exactly what I was going to say in terms of the benchmarking. So what the figures, the targets that we've got currently are very much based on across the region, across England, where other providers are as well.
So are you around how other providers, other areas are achieving? Is that, would you say that's in comparison, or is that better or worse?
for the new birth visit and beyond, so up to 2.5 years, we are in comparison like our neighbours, but the antenatal contact still does need some work, and as Lucy mentioned, we have got a plan in place for to make sure that more families are accessing the antenatal contact, and that is available for all women and families as well.
Okay, can I just ask you as well then? So you changed the basis on which you commissioned the provider a couple of years ago. You're now going out to tender for a future. Can you say what you're going to do differently? Because my assumption is something went wrong words, but there was an issue, and that was then recognised, and the issue around the send challenges. Can you say from what you've been doing to what you will do, some of which you have said about closer working with other groups, can you say what the specific changes would be? What will you do differently? How will you do it differently?
Shall I start? I think there's already a lot of stuff that we are doing differently as a result of where we were. So just some examples of that. We've given the contract, from a public health perspective, additional resource, both in terms of staffing, but also resource to the contract. Our governance procedures are greatly improved in terms of how we govern the contract. We're much better integrated with children's services now, so we're part of the SEND transformation programme too. We work really, really closely with the provider. We have our quarterly contract performance meetings, but we also meet with them monthly as well to be really proactive, because we don't want any nasty surprises kind of coming up. So a lot of the work is already ongoing, and we expect to continue that into the new service. But in terms of what will be different for the new service, maybe you could just talk through those main points around school nursing and the 2 to 2.5 year checks, etc.
Yeah, thank you, Lucy. As well, just in addition to that, we are being really clear with the specification this time, and the contract really articulating very specifically around what we need from that provider, based on the feedback from children, young people, families and our stakeholders. So being really, really specific and clear, not only within the specifications, but also within the KPI outcomes that we want to achieve, and the quality outcomes as well, which I think is very, very different to where we were back when we first commissioned the Healthy Child programme. So just for that reassurance as well. And in terms of what's going to be different moving forward, we will be returning to a universal school nursing offer. We will, the 2 to 2.5 year check will be, the expectation will be that the provider delivers that 2.5 year check. Currently we have got an arrangement with early year settings where they do some of those visits on the provider's behalf. We're going to be much more integrated within children's services within the Families Together model, the Families Together gateway as well. So the entry route will be through that Families Together gateway, hopefully, and then there'll be a team around that request. So then you're assessing that families need more holistically to make sure that they get that right support at that right time, that's right for that family, rather than being sent here and then sent there. So the process should be a lot more seamless in terms of the entry route in and the support that families receive.
That's really reassuring to hear the changes. I think that's kind of where my questions were coming from, not being able to see that from the report. Can I just have one more? It was just about the budget. So you've got your set budget for 10 years, but yet you had to increase this one after 5 or whatever it was. It just didn't seem to stack up, that it's 8.1 million per year for 10 years, when we're going to have wage increases, changes, all the rest of it. Is that a bit of an oversimplification?
So what we're doing is we're setting a set budget for the first 5 years of the contract, and we'll make it very clear that it's a fixed price contract, so we expect providers who are going to bid to ensure that they have some leverage in coming years, in years 2 to 5, to ensure for national insurance or cost of living, inflation increases. And we'll put a clause in as well, so that after 5 years we'll have a meeting alongside the provider, and if the contract is to be extended, then we would review the budget as well. But what we've done previously as well, and it's worked well in two of our previous large contracts, where we make it extremely clear at the beginning that it's a fixed price contract, and we expect providers to budget for any increases in the coming years, which they have done previously. But at the time when this existing contract went out, there wasn't any of that. In fact, what the contract was looking for was efficiencies, because of the way of working and the new model that was being introduced, but unfortunately that didn't materialise. Obviously we've learned from that, so we'll have it as a fixed price contract for the first 5 years, and then there will be an opportunity to negotiate what the contract value would be for any extension periods.
So that's not actually what it is then? It's that what's in here is a bit of an oversimplification then?
Yeah, absolutely, because if we started adding all the little details that the
no,
report
it just would have been
complete.
helpful to have had that really, because that's more realistic.
Yeah, absolutely.
Thank you.
Thank you. Can I just go back to the actual budget? And in there's mention of skill mix thing there. Is my actual concerns will be that instead of sort of having school nurses, health visitors with the additional training that they've actually gone through, that you'll end up with sort of either is like healthcare assistants that may have had some training to actually do that, but maybe not enough to do things there. What kind of clause will you have that the actual skill mix is more qualified than unqualified staff to do all of these assessments?
Thank you. Within the guidance, National Healthy Child Programme commissioning guidance, it's very clear in there around the importance of that school nurse and the health visitor in terms of clinical oversight and governance. So whilst we aspire to have a skills mixed approach, we want to make sure as well that we have those qualified staff in there that we do need to have, and the right amount as well to have that clinical oversight of those that for those staff that might be picking up other things, but that clinical responsibility will still be required for that service delivery, whether that be a health visitor or a school nurse.
Thank you for that. Councillor Smage, did you want to say anything?
Can I just ask a quick question, please? So I'm still not clear, I don't know about anybody else, but I'm still not clear how you're going to improve the identification of SEND children at the earliest opportunity. You've got a paragraph in there that says that's one of the areas of weakness. But then you've talked about mandated visits and you've talked about budgets, but you've not followed that through with how this new contract is going to ensure that you have that early identification, other than links with other areas, etc. Is there not, how are you going to ensure that the provider of the contract makes those connections in respect of SEND? Is it more than just money? Is it training? What is it that the skills that you are expecting of your provider to be able to make those identifications at an early stage?
We'll do a double act on this one. So by delivering the 5 mandated contacts from antenatally through to 2 to 2.5 years, so at each of those contacts, the health visitor will kind of do a developmental check of that child. So at any point during those contacts, if the child isn't developing as expected within the kind of boundaries of what you would consider to be expected at that age, then that's how the send bit would be identified. So it's through the very delivery of the mandated contacts that would happen. And that's why obviously it's so important that those mandated contacts are delivered really well. Additionally to that, I think should we talk about the work with Pecan and Pecan and Pecan, Locala and sorry, my head's gone. The Send Champions. Yeah, sorry.
Yeah, so just to add to what Lucy mentioned, I think as well in terms of that early identification of need, it's so important that those mandated contacts are done at the right time and within those national ambitions and the guidelines that we have there as well. And we need to make sure, and what we have done within the specification is make sure that the pathways, we need to make sure that those pathways are in place to support if needs are identified. As a result of that, what happens, and we have reached out to colleagues and experts within the SEND, within children's, to make sure that we've got that SEND aspect of the specification up to date, where it needs to be, and correct as well. So just as a bit of reassurance in regards to that. Currently with the current provider, we have done a lot of work with Pecan, parents and carers of children with additional needs, and the provider to understand that journey that Lucy mentioned. So they did some work to look back on a handful of families and understood at what time point and what happened as a result, so that they could take some learning, and then from that learning and from that work they then tweaked some of the resources, tweaked some of the questionnaires that they handed out to families as well to make sure that they were more inclusive. And then within the new specification, we're looking to have a SEND champion or some SEND champions as well. So again, really upskilling some of that workforce within that provider to be able to support that wider workforce, whether that's pathways into additional support for children that they may identify that require additional support.
Okay, thanks. Can I just quickly ask as well, on your vision, you've got address the needs of the 0 to 19 local population. Is that all needs, or is that just health needs, or what does address the needs of mean? Is it every need of that child?
I think we'd expect it to be. It's a good point. I think it's holistic. Obviously, for the programme, there's certain specific elements that the health visitor has to kind of deliver on, but there is also an expectation that it's not just about the health; it's about the well-being and the social aspect as well. And we'd make sure that we're very clear within the service specification about that kind of whole child and making sure that it's holistic in terms of the support which is provided.
I've just got another question. Sorry.
Thank you. Is it brief?
It is, yeah. Sorry, it's following on children with SEND. So how are they going to be provided for in the new contract post 18 years of age, between 18 and 25? Because obviously you're not going to have a school nurse there because they won't be at school. So how will the contract provide for those children? Thank you.
I will have to come back to you in regards to the detail of that, but I know that transition is really important. It is something that we have got in the specification, but I wouldn't like to say right now what support is offered at that time point without going back to the specification.
Thank you. Are there any further brief questions?
The mandated visits again, where we've fallen short on the percentages of people that have been seen. Have you got any statistics on whether they've had any issues from these people that haven't had the visits? And also, do we think that it could be people that are not the first time parents, and that they're happy not to have any visits because they've been there before?
So historically, we have done some deep dives to understand why people aren't, having this available visit that is offered to all families in Kirklees at this time point. And some of those points have been raised in regards to, they've had a child already, they don't see the need to have it, or so that has been outlined within those deep dives. And also as part of the monthly reporting that we get now, we do ask the provider to provide on what we refer as exceptions, so we start to understand, why haven't that family taken that visit up, and what's the reason behind that. So we are starting to get that intelligence. So we could provide that if you'd like to see that as well.
Just to add to that, I think it's an important point. Something else which I think specifically around the antenatal contact is the point that we were talking about earlier, around perhaps confusion between what a midwife does and what a health visitor does, and that came out from the deep dive that we did for the antenatal contact as well. So currently the provider are working on some kind of like videos to explain the difference to parents around what the difference is between a midwife and a health visitor. And they're also explaining in the invitation letter that goes through, this is what the difference is, because it is a busy space. And I think as well, just we definitely notice in terms of the antenatal contacts that there's quite a significant difference between the mothers who already have one child and the mothers who are first time as well.
Thank you.
Thank you. I'd like to actually thank you for the actual report that you've actually given here, for actually explaining more in depth sort of the mandated contact visits to us and answering those questions, and also for clarifying that the actual initial contract is for 5 years, a fixed term contract, and again looking at sort of the skill mix of that, so that there is still qualified staff predominantly delivering these actual services. So thank you very much for your time. Okay, we'll move on now to agenda item number 8, which is a report back from the Kirklees Safeguarding and Adults Board, and they are actually joining us online. If you could just introduce yourself first of all, thank you.
Thanks very much, Chair. Can I just check that you're hearing me okay? Can you hear me okay?
Yes, we can.
Okay, thanks very much. So my name's Robert McCulloch-Graham. I'm the independent chair of Kirklees Safeguarding Adults Board. I've got a background in health, education, children's social services, as well as adult social services as well from my previous career. If I can just introduce Jackie. Jackie, maybe you can introduce yourself.
Yeah. Hi everyone, I'm Jackie Stansfield. I'm the service manager for the Kirklees Safeguarding Adults Board.
Okay, thanks very much, Jackie. And Jackie's here to answer any of your difficult questions, just so we can be clear. Firstly, apologies that I'm not actually there in person listening to the last debate. I think probably next time that should be the case. I will be in person next time, I think. It might be helpful within that. So thanks very much for the opportunity of taking you through the report. We've produced a summary of it. The report itself is very long, and we've produced a summary of it in a presentation, which even it is quite long. So I'll go through it fairly swiftly. And then we'll leave some time for questions. Can I just check, Chair, how much time we have for this so I can keep it to time?
We're looking at 30 minutes with questions.
Okay, that's really helpful. Thank you very much. Okay, so this year that we're reporting on, so this is 23-24, was a particularly challenging year, but the previous years have been as challenging as well. What we're really seeing at the moment is that since the pandemic, we haven't really seen a drop in the presentations to all of the services, which all feed into the Safeguarding Adults Board. So you'll see within the report itself, it's a wide range of services dealing with vulnerable adults in Kirklees. And we've seen no let-up of the pressure that's on all of those services. And we've seen an increase, not just in the number of people who are presenting themselves requiring services, we've seen an increase in the complexities of their issues and the level of acuity, particularly within our health organisations as well. So that has put a considerable pressure on all of the services, and that's now coupled with the economic difficulties that we're seeing right across our communities, which seems to be affecting our most vulnerable communities. And again, that's further compounding the safeguarding issues that we're actually seeing. Having said all that, and I hope you can take from the report as a whole, that I'm here in charge to get assurance that there are safeguarding practices in place which are effective. And looking at the commitment and the undertaking from all of the partners within this partnership, I'm able to get that assurance through the processes that we've done. Now, the report itself gives a history and an insight to all of that. So before I go on, just to give you a bit of background to the board itself. So this board has been formed following the Care Act of 2014. It's a statutory group, a statutory body that's there in law and has to be independent and has to have oversight of the safeguarding practices and systems which are in place. And the board has to assure itself that they are effective within that and has to intervene or challenge where that's not the case. There are 3 statutory duties that we need to fulfil within this board. And the first one is to create a strategic plan which outlines the type of work that we expect the partners collectively to undertake, but also individually as individual partners services within this overall partnership. So that strategic plan and the business plan that sits behind it drives that work that we do within there. So that's the first statutory objective that we have. The second is why I'm here today, is to give a report on that strategic plan and the progress that the partnership as a whole and individual partners have done during that year to address the areas that we've identified within the strategic plan. And we've got a few methodologies to actually gain that assurance. One is that we get individual reports coming from each of those agencies to us collectively, based on what we have within our objectives, and I'll go on to that in a second. We also undertake a challenge event every year now, where we have conversations directly with the senior directors and officers within each of those services and agencies, where we challenge them on the work that they've actually done, and so that we can actually get a better insight as to whether or not the services are actually complying with the intentions of safeguarding within that. The third statutory duty that we have is when we have a serious incident, whether that be a death of a vulnerable adult, or whether it be a case of abuse of a vulnerable adult, and where we feel that there are issues that could have been done better collectively, and where we feel that there is learning to be gained across the partnership, we will order a statutory adult review, safeguarding adult review rather, and from that review we will seek to get learning from the incidents, and that will go to recommendations which we'll expect all of the agencies to undertake and collectively, and then we will monitor that through our subgroups to make sure that those lessons are learnt and are in place and that practice has changed accordingly. So those are the 3 statutory duties that we have. What you have in front of you now is a number of principles, values, priorities which are in our strategic plan that we follow We've managed to put it on one page. It's quite complex because the number of drivers to the board is wide just now, and that's why you see so many different things here that we try to work towards. There's 6 values across safeguarding, the 6 safeguarding principles that everybody does nationally within there. We've detailed our purpose. We selected our priorities that we're doing and working across all of the partners. We have 3 subgroups within the partnership, all multi-agency, all multi-services. That's quality and performance, safeguarding adult review, and learning development. And each of those subgroups feed in, you'll see our objectives. So these objectives came from our last, priority. So these are our objectives that we were working towards, is to support the workforce, learn from experience, look at partnership working, and to ensure individuals in particular, and then looking at our engagement with community and making come to that as I go through the presentation. So if we skip on to the next page, so about how the board and its partners have been working towards those objectives. Using different methods or methodologies of disseminating the knowledge that we gain through the experience of actually transferred effectively within there. Every board meeting starts with a story, with a real story from Kirklees, of what helps us actually get into frame of mind to help us with the challenging role that we have to take within the partnership. So in a number of diverse formats now, and again we'll expand on that as we go through. So some of those are emails, learning briefings and newsletters. Now I work across Kirklees, but I also chair some other boards across the country, and Pure Partnership, and the organisation is extremely sound, and that's down to them, and it's allowed Kirklees to be more adventurous in their approach and more experimental in how they actually undertake those offers in supporting the workforce. We focused on these following areas then. So looking at transition with us, we've undertaken some task and finish groups around this to actually examine how we can improve on them, make sure that those lessons are wholly there, and see whether we can actually adapt further as necessary. Mental capacity and our assessments of mental capacity are crucial within our services across health, police and adult social services, as well as the other services or other agencies that support the partnership. A particular theme for us, and that I think it was within the last presentation from Public Health, you will see professional curiosity. Now we expect that of all agencies engaging with vulnerable adults, but also you've heard in the last presentation with vulnerable children and their families. So any professional that we see going into a household, we would expect them to be more curious than the single case that they've gone into, so that they're aware of what's going on in that environment and within that particular household, and that becomes our early warning systems. And those statutory visits that you heard earlier from the health visitors, we expect that across every service to be able to report back to their own service, but also to others where there's a concern. Other areas that we've been focusing on during that year is particularly around trauma, civility and respect, and also support and advice and learning development for carers and young carers. In particular, I wanted to highlight the work of carers, and we tend to use the terminology as unpaid carers, which I don't think really gives proper credit to the work that we receive from carers and families, from friends and families going through there. Without that work, our services would fall over. It's a hugely important resource that we have, and we want to make sure from us, as a safeguarding role, that all of our agencies are in support of those carers, and that's one of the areas that we look at in particular. But we move on, just conscious of time, got a lot of pages to get through. Okay, and just an example of some of the events that we've done. So as well as giving that range of engagement that I've just gone through, we've run some major network events during that year, and we continue to do it this year. So the board's Dignity and Care Steering Group focused on carers and working carers, like I said, and they organised a network event, Navigating the Careverse, because that careverse, excuse the term, is a very complex arena, And it's very difficult for people who become a carer or have a loved one that suddenly needs support and perhaps guidance from a range of different services. It's really difficult for them to navigate that. And so the board itself has been trying to support that, and we've done that through some of these network events. Just to note there, we had within that event, we linked with a partner of Carers Count, which is a not-for-profit organisation, who are so well rooted within Kirklees that their insights were invaluable to that event, and it went down incredibly well. Sorry, Jackie. So still on supporting the workforce, we take the experiences of people who have got a lived experience as a very valuable resource for us. And we're trying to ensure that we hear the voice of the individual through everything that we do. And it's something that we check through our challenge events when we're talking to adult social care, we're talking to our health trusts, we're talking to our police force and others within that. Do those individuals, do those practitioners actually hear the voice of the people that are using their services, and are they designing their services around it, and are they cognizant of their experiences within everything that they do? And that's something that we constantly go back to, and we've adopted for ourselves within our own practice on the board, that we ensure that we as a collective are informed by those voices and informed by those cases. And we've now taken a step further, that we look beyond Kirklees as well to some of the national experiences that are coming through, and then particularly from our legal aspect and our legal support that we get from Kirklees Council. They give us case studies from court cases that are going on across the country, which are really insightful and really cause us to think and look at our own practice here locally within that. That's just one example that we do. So moving on, I've touched on network events, so I think we can skip on. So looking at learning experience, and again, I've kind of talked about this already within there, but the particular challenge that we have, and all safeguarding adult boards across the country are challenged with this, is to embed learnings from our task and reviews from our task and finish groups, but also from our safeguarding adult reviews. And we're looking at processes as to how we can actually get that through to the front line, but also to the managers within each of the services and how they design them. And that practice from the SARS and domestic homicide reviews, but also learning from our children's safeguarding practice reviews as well. And this is what is so particular around Kirklees, which we're not seeing in other boards elsewhere, is over the last year, there's been a real drive to work more collectively with the other two boards, with the Community Safety Board, but also with our Children's Safeguarding Partnership as well. So the three boards coming together, because so much of our work is similar or identical in some cases in what we do around safeguarding practice, that it's important that we work together, not just for economy of scale, but just to make sure the learnings pass through. And one of the things that we've learned from this, and from some of the SARS that we've undertaken most recently, is that there's a focus on the family or within the household that we could be doing more with. And that's come out from the SARS and also the reviews and the task and finish groups. And that's as relevant to us within the Safeguarding Adults Board as it is to the Children's Safeguarding Practice, as it is to the Community Safety Partnership as well. It's all similar within there. So that's a particular focus we've been doing over the year, and we're maintaining that moving on. And you'll see later in the report, when we do future work within there, we're looking to see how we can further share our experiences across those three groups. Thanks, Jackie. Again, some learning from experience, some other examples are given here, and they're expanded on in the full report. We've used videos, we've used storyboards, we've linked with organisations looking at how this can be covered in their supervision, their managerial supervision going through, and the partnership network events to showcase new resources. Our website is extremely well used as a newsletter, and we've run short lunchtime lessons for people to sign into and to gain that experience. So whatever way we can actually get the message out, we're actually taking. We think we've just about exhausted every methodology, but we're always looking for more if there's something else we can do. And one thing to say is that we don't do this once. We can't just do it once because our workforce changes. And it is a case that we need to go back and check that those lessons that were learned 2 or 3 years ago are still, people are still aware of it, and the recommendations are still in place. And there is more that we could be doing within that particular area of work, and that will take some further resource to be able to do it. Working across the 3 boards, we hope to be able to create that resource so that we can go back in and do that. Okay, next page. Just really, I think I've touched on this already actually, but it's just to emphasise, one of the areas that comes in multitude of safeguarding adult reviews, not just in Kirklees but across the whole of the country, is the application of the Mental Care Act, and trying to identify whether individuals have capacity or not is a crucial issue that comes up time and time again, and it's an area that quite rightly features highly within the training that we offer, but also the training that each of the different services do, and we link them all together within there just to emphasise that particular area of work. Okay, moving on to partnership working. I have said already that the partnership in Kirklees, I described it as a mature partnership. It's a very effective partnership. People who sit on the board have 2 roles. One role is as a representative of their agency. The second is to be a safeguarding champion that actually challenges, is able to challenge collectively and other individual services at the board and through our subgroups within there. And we relish the use of the word challenge, and it's something that we encourage, and it's something that we support within that. I'm conscious of time, so I'm going to shift over a bit. So I think I've said all the things I need to say really about partnership and community engagement. One particular area, so we highlighted this in 23-24 as an area that we wanted to develop further, and to actually get more of that voice, and also to get the message out from the board to the communities. I think there's more work for us to actually do in this one, and we've had a further think about this in our development sessions. And what we want to do now is recognise that our board itself hasn't got a huge resource that can go out and do that. However, our services do. So that we're going to change our approach to community and public engagement, and actually the board's function in that is to be driving each of the services that are part of the partnership to undertake that public engagement, and so we can make sure the message comes back to the board. So I think we've accepted that as a learning from 23-24, and we're going to carry that on to 24-25. Okay, next slide. Right, this is a particular strength of the partnership, and to be honest, I'm stealing it from Kirklees and introducing it in other areas where I'm actually working. It's a piece of good practice. It's been embedded in Kirklees for about 4, maybe 5 years now. And I've touched on it before, so I won't linger too long. But this is an exceptional piece of work where we have a group of individuals, including myself, have a conversation with the leads of each of the services where we challenge them on the practice, but we also hear from their experience of the previous year around the objectives that they've been working towards in that year. And in 23-24, we were looking at these 4 areas that we've just actually had the story coming back from each of the agencies which gone into the annual report. We're looking again to the challenge event this forthcoming March, the next one, and this was working into our forward plan. We've had a recent development session across the board, which we used the strategic development group to lead on, and talking from the range of services presented, the 5 areas of concern or objectives that we should focus on over the forthcoming years is going to be transition again. As I said, that was always there. Domestic abuse, and the slight difference with domestic abuse, and I know again it was touched on the last presentation. The presentation of domestic abuse perhaps hasn't changed, although the focus has shifted, that we are seeing more cases which are involving much more elderly individuals, as well as some of our younger adults as well. So there are 2 areas that we need to be putting a closer microscope on so that we can actually analyse that. And again, domestic abuse cuts across every service. Work with families and households, I've explained already around that. A lot of our services go into a household with a single issue, or a single individual that they're trying to work with, and what's often missed is what else is actually going on in that household. Are there other adults that are vulnerable? Are there other adults at risk beyond the individual that the service has gone in? And it's that professional curiosity to take that further forward within there. Any eyes that we have in the household are useful eyes, and we need to make best use of them. Community work and community networking, again, is a priority for us in this forthcoming year coming up. The last one is not really an objective, but it was put into one of the concerns that we have. The economic crisis that we're in currently, each of our services have to make every penny count. And we're looking to the partnership itself to actually help us and help individual services ride that out. The actual partnership should actually produce efficiencies within itself, and we're looking to see how we can actually manage that in support of all of our services. So to end with, my position is independent. I don't report to any service. I'm appointed as an independent chair. And to give a comment on practice, I have challenged other practices out with Kirklees, but I have to say what I've witnessed in Kirklees over the few years that I've been here now is a partnership with excellence, and one that has challenges that they're willing to face up to, and no one is hiding in the shadows. They are very willing to come out and actually share that information with you. I think I might have ran over a little bit, so I'm sorry for that, but I'll open for any questions. Unless, Jackie, did you want to add anything?
No, I think you've covered everything. Thank you.
All right, thanks, Jackie. Okay, yeah, I'll hand back for any questions.
Thank you for that very comprehensive update on what you've actually been doing, plus the actual annual report that came with our papers. One thing that I must say that is in the actual annual report is the use of like case study scenarios, because sometimes being able to see something working in action really does actually help there. And also looking at the joint, it also gave sort of the joint approaches to all the multiple agencies that actually sit on the board, so thank you for that. I've got a couple of questions that are probably more Kirklees Council specific. Is what percentage of Kirklees employees have actually received some kind of basic safeguarding training?
Right, I did say
We
any
don't
difficult...
collect that data.
Sorry, can I pass over to Jackie?
Yeah, we don't collect that data.
All right. So I think we'd have to go back to adult social care and probably the training organisations within the council to do that.
Yeah, the training that we offer is multi-agency, so it's opened up to the whole partnerships at anyone who's working within health and social care. So the independent sector, voluntary sector is able to book on our training. So we keep account of who's booking on, but unfortunately we don't, in each organisation, don't know what population we're reaching.
Thank you.
Thank you. It's sorry, Kath Sims, Service Director for Kirklees Council. Just to say, it is mandatory training, the basic safeguarding awareness, so a lot of the board don't capture that data, but we do. So all of our adult social care workforce are required to do the basic training.
The further question that I've got is, if say a member of the public has got a niggle, a gut feeling that something isn't right, is not a criminal activity, they can't say it's domestic violence, there just isn't something right, where would they actually go to, and how is that actually publicised?
There's a number of areas that can be done. Each of the services do their own. So going back to adult social care will have a way into them, the police will, our health colleagues will, and even Health Watch and Locala, they'll all have different ways that the public can actually come in and get those services within there. We do publicise our own website within there, and there are ways that people can actually raise issues with us, but in most cases we'd actually direct to a relevant service. So it's not a function of the boards to be actually doing any of that particular practice. Our function is to assure that those practices actually are undertaken well. So that's kind of our role. But we would ensure that the public can have access to the services. So that's one of the things that we would be picking up in our challenge events when we actually talk to any individuals from those, any officers or directors from those services. So how do they do that?
Thank you. That's what I actually meant is obviously that you would have some oversight into how people actually were able to access the help that go, because obviously for some members of the public, it's not a police matter, but there's just something not right. But it's good to know that you have some oversight there. Are there any other questions from the panel?
Yeah, my question's on similar lines, actually. So I was thinking about perhaps vulnerable people, elderly people, people living in sheltered accommodation. Do they have, are they aware of who they can contact? Do they have any contact details, again, for people they should contact if they're worried or they're concerned about something that's going on? Do they, you know...
Again, that's for the actual services itself, actually. So, like, just the role of the board is to make sure that the services are operational, that they've got safeguarding systems in place. So, if you take sheltered accommodation, for instance, we'd be interested if the housing provider, if the adult social care services, and the police actually are responding effectively to them. So that's what we would try to test out. And some of it's through data that we actually get. A lot of it is actually through our questioning and going into particular issues that have been raised. But also if there's a safeguarding adult review that's been undertaken, we would do a full independent review. We'd appoint an independent investigator review and going through in those sort of cases. So it's kind of multifaceted for us as to how we gain our assurance that those services are actually in place. So there's a particular case outside of here where there was an unfortunate, it's in London, an unfortunate murder in a sheltered accommodation facility. There will be a review there. We will take those lessons here and actually take them back to the providers in Kirklees and say, this is the findings that we found out within this case in London. Can you assure us that that won't happen here? And that's the type of questions that we do. And some of the other national cases that we've heard elsewhere. There was one last year around in the learning disabilities facility across in the northeast. There's a significant review undertaken there, national one. We again asked that question here to providers. Could this happen in Kirklees? And if you're saying no, how do you know? That's the type of challenge that we would do.
Yeah, I was just going to say, so as councillors, I think it's really important for us to know who we can contact. Perhaps this is something that, we could raise with officers about who we should contact if we're concerned about a vulnerable person or an elderly person, an adult. We need to know who we can contact as well in those circumstances. I think it would be helpful to have, a name or a contact email, phone number, things like that. It's not something I personally have, so it doesn't matter the councillors.
You can actually find out that information, but it was going round the houses for when I had two safeguarding issues, but I do feel that it might be something that we could look at councillors' induction. And obviously for those of us that aren't new councillors, is maybe having some kind of briefing that we could actually go with those things. But I eventually found out the number that I needed.
So shall I jump in there? So if it's in regards to reporting by the local authorities, so all safeguarding concerns, so if there's an allegation of abuse or neglect, it would go via the local authorities' front door service, so that there is a telephone number for the public, but most things are online, so that it captures the right information as well, so people are putting the right information, so it's kind of get dealt with more effectively. There's online reporting, but that's via the local authority, obviously. If it was someone needing health, you go through those channels, but everything that the board focuses on is around people with care and support needs and allegations of abuse and neglect. but that's managed by the local authority. Adult Social Care as the lead agency.
I think, Chair, if I can, I think in the actual report, the annual report itself gives an indication as to the front door and the traffic at the front door, really. So the number of concerns that come in, and the number of concerns that turn into investigations and the outputs from that. So the report itself gives a response, and that's the level that the board operates at. So we are giving ourselves assurance how many of these concerns coming in are actually being dealt with and dealt with effectively. That's the kind of question that we do in a global sense. And if we find that's out of kilter from any, from a national perspective, then we do some more deep dives. We come in and ask particular questions. Why is that not working, or why is it okay? But the report itself is actually giving you a fairly good picture, actually, of what we have. It's showing that there's an increase in the number of referrals coming through, but it's been dealt with here. The other thing it does, actually, which is of interest, I think, to all services, is identifying where the referrals are coming from, or where incidents of abuse are actually taking place within that. And I think, again, we would say that Kirklees is kind of mirroring what's happening nationally as well. So there's nothing untoward there. But that gives you an indication as to the scrutiny that we provide as a safeguarding board across all of the services. And we would include council services within that.
Thank you. Are there any further questions? Briefly. Councillor Addy.
I just wanted to reassure members that if they did have serious concerns about social care needs in a specific case and that, they could always come through me. But if you're looking at initiating that first contact and concerns, it'll be through the adult social care front door. And I could also make sure that all councillors get a briefing, a little note with some contact details for you. So I'm happy to initiate that.
Thank you, Councillor Addy, for that. Are there any further questions? Can I just actually thank the Safeguarding Board for the their presentations today. And one recommendation that I would like to do is that when new councillors have their induction, that there is a period of safeguarding training plus contact details, what you could actually do, be implemented on that training. But thank you.
Thank you.
Thanks very much for your time.
Thank you. And moving on very swiftly to item number 9, which is the Joint Health Overview and Scrutiny Committee updates, and Councillor Smage has kindly agreed to give that briefing to us. Thank you.
Okay, thank you. So you've had the reports from the 3 Joint Health Committees that are currently in operation. So you will see from the Calderdale and Kirklees Joint Health that we have a list of items that we're wishing CHFT to come to the committee with. We have a meeting in March. Our next meeting is in March. There are several areas that are required for the implementation. So there is capital that has been set aside for the building changes that are required. There are building changes required at Calderdale before services are reconfigured. And so what we've been looking at is we've been having updates as to the read the discussions with the Treasury that CHFT have been having in relation to their outline business case. There is some building work that has been started at Calderdale, which is the car parking and the Learning and Development Centre. And then once the clinical build has been put in place, then we will be looking at how they are going to implement the reconfiguration of services. They already have done the work at the emergency department in Huddersfield, and the committee were able to look at those changes before that facility opened. And excellent facilities, I thought. So that's where we are with the CHFT. We've also been looking at the maternity services across Calderdale and Kirklees, and you will have seen that we had an update last year from the maternity services, and Mid Yorkshire have opened the Bronte Birth Centre and are working closely with CHFT to look at whether Mid Yorkshire can expand the use of the Bronte Birth Centre. In relation to the West Yorkshire Joint Health Scrutiny Committee, information is there. We had a meeting yesterday for the Joint Health Scrutiny Committee, and one of the items that we had on the agenda was the non-emergency patient transport services. There is a new eligibility criteria nationally for non-emergency patient transport. It's not the blue light ambulances or anything like that. It's for the non-emergency. And we've been looking at the mitigations that they're putting in place. So anybody with physical mobility or a medical need that prevents them from safely travelling to hospital for appointments, they will still receive the service. But there is a portion of users who may not be able to use the service after the new national criteria is applied. And so we've been looking at those mitigations, and some of those mitigations include the use of community transport across the 5 districts of West Yorkshire. We did have some recommendations because they're going to a decision on this at the ICB on Thursday. And so we have put recommendations in from the Scrutiny Committee yesterday ahead of that meeting tomorrow, which include that they're going to have some town hall engagement events, and we've asked for a communication plan. You would expect us to want to look at that. The ICB considers in a future overall approaches and plans the relationship of transport in any service reconfiguration, etc. And that the availability of public transport, particularly in rural areas, is considered. And that they're looking at a pilot for a prepaid bus ticket pilot, and we didn't have any information on that, so we're wanting more information on that, and that people should be able to have a safe transport service. So we're wanting more information on the community transport schemes across West Yorkshire, whether they're commissioned by the ICB or commissioned via another means, so we can see that there is an equitable provision across the board. Okay, and then we also have the Older People's Mental Health Inpatient Services Joint Health Scrutiny Committee, which is really, I would have said, in the final stages of deliberations. So we were supportive of the option 1A that was consulted on. We're expecting to meet with them again, that committee. It wants to look at workforce planning and business case and implementation plans. We did receive a letter in November saying that the Mental Health Trust had taken the decision to go with option 1A, which is a dementia service. This is inpatient dementia service located in Dewsbury, 2 separate male and female wards, and then other older people's mental health needs in relation to inpatient in Wakefield and Calderdale, and there would be beds in both of those hospitals for that. So that now we're just waiting to put a meeting in to look at those extra items that we've asked for. And I think that's a general update. But I know that some of you are on those committees, so no doubt you'll have your own updates as well.
Thank you, Councillor Smage. Is going back to the community transport.
Yeah.
I know from personal experience that in Todmorden there was a really good community transport service. I think it might have been a small subscription. because they used to bring patients to Calderdale for us to actually see. I think there might have been one similar in Denby Dale, but I didn't really have much thing there. But when you're talking about commissioning, are they looking at sort of expanding similar things to that, or looking at, I think it was like Roundtable used to do various things. We had initiatives when I worked at Dewsbury District, they brought in patients for us and various things.
So what we're looking for is more information exactly on that. So there are some community transport that are commissioned by the ICB and others that get their funding from elsewhere, whether it's lottery or whatever, Rotary or whatever. And so what we're wanting to know is we want to get a picture of how that community transport is working across West Yorkshire, so that we know that we can have assurance that wherever you are, you can have that option. There is that option, rather than is there pockets? Yeah, is there pockets? Yeah.
Thank you, Helen.
Just when you said about where the inpatient places were, is there no facility within Huddersfield and South Kirklees? Because did you say Dewsbury, Wakefield and Calderdale? So there's nothing in Huddersfield, so there's no sort of... Will that be the case in the future? Because I'm not aware what 1A is.
Okay, so it was the details are that, and it's inpatient only, okay, that I'm talking about. So the dementia service will be located at Dewsbury. So this is for Calderdale, Kirklees and Wakefield, across those three authorities for the Mental Health Trust. That's 30 beds. And then for what they call a functional mental health need, yeah. So the Crofton ward at Field Head will have 26 beds. The Beechdale ward at Calderdale will have 16 beds. And this is for older people's mental health. And so there would be 42 beds for a functional health needs service in total. Okay.
But quite a distance for anybody from Huddersfield, South Kirklees. I mean, I was quite surprised at that there's nothing in... It seems to be like, if you look at the map, there's three within a... But actually there's a big space underneath that's not...
But those are where the units are. So there's a unit at Calderdale, there's the Priestley, there's a unit at Dewsbury, and there's a unit at Field Head. Yeah. So those were the proposals that were consulted on. So yeah.
Wow, right.
Yeah, but I agree. There's, it is a distance for people to travel, and this was one of the things that we asked about, was the travel and how carers can get to these facilities, so that people can have visits, etc. Because it's important that they do while they're there. Yeah.
And the fact that those people are like the people we're visiting are likely to be elderly as well. So you're looking at probably an hour is the shortest route by public transport, up to 2 hours to go elsewhere.
These were the points that the Scrutiny Committee made. Yeah.
Thank you. Are there any further questions? Councillor Smith, can we just thank you for the comprehensive update there? And the last item on the agenda is just our work programme. We've got our last meeting of the municipal year in April. Where we should hopefully be looking at access to dentistry, and the Children's Scrutiny panel will be joining us there. We also have raised a number of issues around sort of various others, is not only just with the surgical dentistry, but with the actual routine appointments, although there's a long wait for orthodontic care, and we should also have an update on the Kirklees QCQ inspection. And if there's no further questions, can I close the meeting? Thank you.